Good afternoon, everyone. If we want to be on schedule, we should start now. It's already 2:30. So I would now present Mr. Jean Guillaume Simard. He's a teacher at the Department of Urban Development and Planning Techniques at Jonquière, Cégep. He's very much involved in developing several research projects with ECOBE, research and transfer. And he worked with the Jonquière Neuromuscular Clinic on a project to analyze the logics of people with neuromuscular disorders' residential choices as they relate to the socioeconomic characteristics of their residential neighborhood and their level of access to services. His expertise focuses on regional and rural development, the socio-geography of education and health, as well as land use and urban planning. He shows strong interest for issues relating to monitoring of school indicators and living conditions, accessibility of health services, and spatial epidemiology. And Jean Guillaume is not alone. He will be with Cynthia Gagnon, ergotherapist and prof at Research Center Charlemagne at the University of Sherbrooke. The floor is yours. First, we will talk a bit of the context of myotonic dystrophy, but you've heard a bit about it in the various presentations, and we want to tell you a bit about why we thought it was interesting to talk about residential logistics. As we know, myotonic dystrophy is a multi-systemic disease affecting the muscular system, but also the connective and nervous systems, the digestive, cardiac, and endocrine systems. It's a hereditary disease, and it's a dominant disease. Many members of a family can be affected. It's a multisystemic disease, and there are 4 clinic phenotypes. Whether late, that is a person with very, very little affected, who has developed cataract a bit earlier, or the adult type, starting around age 20, and cognitive profile also. Finally, we have more the pediatric forms, juvenile, infantile, or congenital. Congenital, we can have severe symptoms of dipotomia as soon as at birth. It is a rather slow progression and quite variable according on the symptoms. Some can be very little affected, but others can be very much affected at the muscular level, but not at the cognitive level, but it will come with time, so it varies a lot in the clinical presentation of these persons. It is often considered as the early aging process. What we observe is a profile that will associate with the aging person. She will lose slowly her muscular strength, but won't necessarily go towards dementia. Now, what we observe is that the social participation of these people can vary very much from one to another, but between 25 to 60% need assistance or do not realize, cannot go about their everyday activities. Each sector of social participation, some are affected differently and more acute and more or less acute. What we wanted to look at, and some persons may have seen the presentation of Catherine Raymond, my PhD student. Well, we don't understand very well why it is that we have some persons who remain very much autonomous and others more rapidly are affected and limited in their daily activities or in their social activities. What we see today is that we don't have a treatment for myotonic dystrophy. There's no cure. So what we do as stakeholders, we do a lot of adaptation and we modulate environmental factors. Adaptation of the home, access, service at home, cleaning services, help for meals, budgetary support, etc. What What is also quite particular with DM1 is that previous studies that have been carried out throughout the world indicate that 42% of those affected depend on welfare, so they're poor, and there's also less social support because DM1 is a hereditary disease, so many members of the family can suffer from the same limitations, and they're not necessarily able to offer support that could be expected if we had only one member in the family who would be affected. So what we see is that about 53% have little support from the family. What we can observe also in these rare diseases, we're a bit more lucky in Quebec in terms of neuromuscular diseases, but elsewhere in the world, there is really an underdevelopment regarding this disease. Little access to services, bad diagnosis, and when they meet finally actors of the health system, they don't necessarily know what myotonic dystrophy. And it's difficult to have good policies for these people. One of the issues that we had was the persons suffering from this disease, do they have access to the necessary services in their very environment to help them carry out their daily activities and social concerns? One of the questions I had as an ergotherapist, I could see that people had nutrition profiles that were quite weak. They used to eat a lot of already made products, hot dogs, etc. Is it because they have only general stores, so they cannot buy an apple $1.50? So is it a question of access? And also given the difficulty of moving about, low income and other factors, it's a very important notion to know if they have access to services that are important for them. So what we could do if we would know that is when the person is looking for a home, we could reorient that person towards an area where there are more services. We could say to them, well, that would be better for you to live here, and with respect to the services offered in a given neighborhood. What we have to see, it is a early aging model. We cannot think that the municipality would do that only for myotonic dystrophy. But if we demonstrated for this disease, we could say it could be also applied to the aging population in general, and thus we could justify a better offer of services in certain neighborhoods, for example, where we have certain services, mobile services are not present because they're far away from downtown areas. Maybe we could give more services there, and that could apply to an aging population in general. So Jean Guillaume is coming now here. Why did we choose Saguenay? Well, we wanted to do a link between social participation and environmental factors. What we need is a lot of persons in the same territory and territorial limits quite well defined. Saguenay, if you know the area, for 2 hours there's nothing before you get there. It's very clearly delimited. We are about near 100% autonomous in terms of health services, and we have quite homogeneous services. We have also a specialized clinic there for some 30 years, so we have access to about 450 persons suffering from DM1, and we have research infrastructures which allowed us to look at the sociogeography of the case. So that's how we decided to work together. I didn't know much about sociogeography, and he knew nothing about DM1, and now we are learning from one another. And what Jean Guillaume will give you is the preliminary results as regards the logistics of the homes of the person suffering from this disease. And our region could become like a lab for this disease. I am the one who went towards Cynthia, not the other way around. But I think I'm not the only one that went towards her. So, in fact, what is at stake here, Cynthia mentioned it, we wanted to better understand, better analyze, better characterize the life environment of the person suffering from neuromuscular diseases, in particular myotonic dystrophy type 1. So we wanted to analyze that with respect to the fact that some of these persons seem to have a lower quality of life, a low income, but also access to service. If we wanted to know if they had access to the same services and necessary services to carry out their different social roles. So that's what we did. The territory that we studied was the metropolitan area of Saguenay. It's more than the city of Saguenay. It covers Saguenay and the various boroughs, but also various rural municipalities around the center of Saguenay. So 7 rural municipalities. And we analyzed, in particular, the polling sectors, territories that have been developed by Statistics Canada. So that's the territory in question. So what I thought was important also was to not only look at access to services, socioeconomic composition of the boroughs, but also we wanted to understand better what Saguenay was all about. It's flat, it's is it urban? What is urban? What is rural? That was the first analysis that has allowed us to divide the various boroughs according to their level of rurality and urbanity. So we see that urbanity and rurality, it's 2 worlds, and it's quite important when we talk about access to services. So what we can see here, mainly, it is in the centers, more urban centers and downtown areas where we will find more density, urban, residential, urban, unifamily, and a bit around that rural territory, a lot of green space, agricultural land. It's not that surprising when we realize here we have the parameters of urbanization in which we will concentrate development, be it residential, commercial, or industrial. So we can see that this occupation of the land will be quite diffuse on this territory, which made the analysis of the problematic quite interesting. But globally speaking, I worked with the municipality of Saguenay. This information, they didn't even have it at the municipality of Saguenay. So we made a first analysis regarding socioeconomic data. We regrouped, we made categories based on variables such as income of families, proportion of low-income families, rate of employment, in order to characterize these neighborhoods in function of their income. Here we see a quite varied picture, the urban centers where we will have more low-income families. So after having done that, we wanted to localize the persons with DM1 in Saguenay. This is a map of prevalence that was drawn with the addresses of these persons, and we made calculation of prevalence, so rates per 10,000 inhabitants, in order to cross this information with respect to access to service, composition, socioeconomic composition of the neighborhoods. So this gives us another element for our analysis. Finally, the last element at the center of all this was the measure of this access to the services. It was quite an issue because, on the one hand, it was easy to make the calculation in order to, based on individual persons. We could take a person and measure in kilometers the distance to the service, to the closest service. But also, if we wanted to make a correlation between this information and the rest. We wanted to have the information per neighborhood. So how did we go about this? We looked at all the residential buildings on territory, 75,000 buildings more or less, and in each case measuring the distance between it and the closest service, and wanted to calculate per neighborhood average distances. So we did that for various services. Cynthia talked about grocery stores, back to big supermarkets. We did that with government buildings and other such services. So this is the map that was a result of that. This is the average distance to have access to a health service, first-line health service. The dots are the services as such, and we have the distances in kilometers, less than 1 kilometer, less than 1, up to 35 kilometers. That may mean that the more peripheral neighborhoods will be further away, of course. And this kind of maps, we're in Saguenay, again, to the north, no much services there, because it's the north of Quebec that starts there. So it's quite realistic. It would be different if we would do that in a context such as Quebec City or Montreal. So with this information, what did we do? We crossed this information. We wanted to know what kind of result we could get from it. A few observations coming out of this. The research indicates that there'll be a link between the concentration of the ill persons and the level of low-income families with respect to higher income families. So 2.8 cases against 1 case per 10,000 inhabitants. So it's a clear observation. It's interesting. We had some indications individually of that. Now we can see it more statistically. We can broaden this observation to a whole neighborhood. We saw also that there was no difference in terms of concentration based on residential density, that is, rural or urban character of the territory. So we see that there doesn't seem to be any difference between rural and urban territories. That was also representative of the population in general, and so there's a more diffuse residential logic. Also, we cross the severity of the disease. It doesn't seem to be linked to lower income or distance to service. That's a chart we developed to show averages, distances in general for all the persons of our study, and the percentage of these persons with respect to the average distance to go towards a service like specialized health services, pharmacy, medical services. Specialized services, 42% will have to go less than 1 kilometer. 39% between 1 and 4.9 kilometers to have access to a doctor. So strong concentration or under 5 kilometers. But what is also interesting is all those who are not in this limit of between 1 and 5 kilometers. If we look at certain functional issues, and also 60% of the persons do not have a car and will be dependent on others with respect to mobility. Reflection around accessibility. This project is very experimental, if we can put it that way. That has allowed us to develop a methodology. The project has been funding for another 2 years by Quebec research funds. Santé, health, society, and culture, but we said it's not only based on health. That's why culture has also funded us. We want to broaden the mandate to look at the environmental factors, but for all of the province of Quebec, in partnerships with the Neuromuscular clinics in Montreal and Quebec. There's also an aspect we want to develop is investigation. We want to we want to know more about the various constraints linked to the use. It's very theoretical here. We want to look at the context, transportation, mobility, the perceptions and the constraints, and the real actual utilization of the services. I also look at this. I like maps, as you can see. So I created a few maps similar to what we've done in Saguenay, but for all of Quebec. We see access to services in Quebec, medical clinics, same kind of structures as earlier, less than 1 kilometer, 1 to 5, 5 to 10. We see that the Quebec territory is quite vast, so the population is quite spread out. So that's what we're looking at. That's what we use to make this kind of analysis to apply our scheme, for all services in Quebec. This is really a premiere. It's the first time we do such a thing, such a map. Also, land occupation. We talked about urban and rural a minute ago, so it's a bit similar here. We have forest, urban, rural, and peri-urban. So we see that the population here, we see the result. And also I made some crossings. The hierarchy we saw earlier, the populations linked to each group, and the main characteristics. We see that the majority of our population will be in urban areas, 5 million out of 8 million, more or less, but still about 2 million persons will be in the forest, rural or peri-urban areas, where the distance in average will be around 40 kilometers to have access to health services or drugstore. It's also interesting in terms of aging of the population, for example. So that's it. So as Jean Guillaume has mentioned, it was an exploratory study that had never been carried out, so it was very interesting. In the 2 first years, we really looked at the data. Now we want to know more in depth certain environmental factors, access to supermarkets, for example. And with our questionnaire, well, I'm going to give you, for example, we can be beside the IGA, but we might not want to go there because we don't like IGA because we want to go to Metro or Super C. So we want to look at with the next study. Well, we have done a good job describing the Saguenay territory. Now we're going to go more in depth in the questionnaire. What is your main supermarket? Do you use another one? Is distance an issue? Or collective transportation, for example, in the big centers is much more efficient than in the Saguenay area. There's no adapted transportation between Alma and Jonquière, and the specialized clinic is in Jonquière. So people go to Alma, and what is going to happen if they want to go to Jonquière? You know, it's magic or what? So there's a problem with respect to territories in these less urban areas. So, and it could justify to have additional services. Neuromuscular clinic, it's quite different in Quebec or in Montreal, but when we talk about the rest of Quebec, how we are going to organize access to specialized clinics, and how could we justify, for example, tele-adaptive rehabilitation, access to very specialized clinics. We don't have to even touch the patient. Somebody else could do that at a distance, and the physiotherapist, the neurologist, the ergotherapist can observe what happens and make recommendations. So, but this must, before that, we have to have a justification process beforehand. Justify the development of new services or access to already existing services in the Saguenay area. We're quite lucky. We have CLSC, where the client is not really, doesn't really fit the aging person profile. When the person goes elsewhere, moves away, we have to be able to demonstrate that they need these services and that the current services are not sufficient. And what I said earlier, we have to be able to target higher income boroughs, because people will have a mobility. They're going to, you see in Montreal, everybody's moving out on July 1st. So if we could say in link with your neighborhood, there are some neighborhoods where you have more access to services. There are other factors, of course, why a person may want or not want to go to a given borough, but access to service is certainly a point of importance. If we really want to offer services and make sure they participate more socially. So that really completes our presentation. Maybe you have some questions. Do we have time for questions? 3 minutes, I think. Questions? You have measured access to healthcare services, but what will be your, how are you going to measure the improvement? How are you going to measure that satisfaction of the patient, etc.? We're not there yet, but theoretically, I can give you an answer. If we were able to say, for example, that the patient will have 120 kilometers to go to a specialized clinic, and the day where we have tele-rehab, he must go to the local social center. It's 4 kilometers away, so that gives us an idea. Also, the frequency of use of services, we haven't started looking at that, but we will. People will go and make their shopping once every 2 weeks, so it's fresh vegetables might not be so fresh. So if we have delivery services, internet delivery, and orders and delivery, you don't even have to get out of your car. If you have a mobility problem, it's quite something. That will limit the problems of access to super centers, etc. If you go to a small store at the corner of the street, you may pay $4 for your box of spaghetti. So it's not logical. If I can't afford the spaghetti at $4, they can't either. So access to services also regarding Quebec, it's not the same, but in Canada, the U.S., sometimes there's one very specialized clinic in BC, and BC is quite big from north to south. The same thing in the U.S. I promise you, they go from Arkansas and they go to New York to their specialized clinic in New York. You need some means, and most of our patients will not have access to that. So is there some other way? But we have to document that first.